This next part 2 for renal stenting cases, as part of the chapter for meat, was an interesting case. This is one that we saw in clinic several weeks ago, and it's very recent. It's the interesting case regarding it's an 87-year-old male with a history of malignant hypertension with symptomatic episodes that has brought the patient to the emergency room on several occasions. The patient is on 4 to 5 medications for blood pressure control. He had a renal stent placed at an outside institution approximately 6 months prior. On ultrasound evaluation, it had abnormal velocities. So we considered performing a 64-slice CTA scan of the renal arteries. Here's the CT three-dimensional images. You can see the stent in place. And the first thing that you can notice is the left renal stent is long and it has missed the mark, and that is not on the ostium. You can see the gap between the ostium of the origin of the renal artery and that of the stent. And on this view, you can see the cross-axial images that flow through the stent, and you can see the hyperplasia that's developed on the proximal end. So when you look at the MIP images on the CTA, you can see that the ostium has been missed, the stent is too long for this lesion, and there's a development of significant hyperplasia primarily at the proximal end. There is some disease as well on the distal end of the stent. One thing that's beneficial to CTA is you can get measurements, and you can see the size is at least 15 millimeters required to stent on that proximal end. So an angiogram was performed. You can see the guiding catheter near the ostium using the limited no-touch technique that we talked about, and you can see the hyperplasia that has occurred on the proximal end. So one of the questions is, how would you treat this lesion? Obviously, you need a 5 or 6 millimeter stent in order to cover it. It turns out to be 6 millimeters based on the measurements. You can perform angioplasty alone. You can consider bare metal stenting, or you can think of using a covered stent in order to treat this proximal area. And so you may have to ask yourself, are we making this renal stenting too complex, like this road here in Nice with all this confusing traffic signs? Just go ahead and stent it and be done with it. And so that's pretty much what we decided to do. So you can see we go ahead and crossed it with a wired 014 wire. This time it was with the use of a Spartacore, giving us the extra support. The wire crossed past the lesion fairly easily. You can see on this run the wire in position across, making sure that we're not through any struts, and went ahead with putting a Cordis 6 by 15 millimeter stent in position, and it crossed the lesion fairly easily. Predilatation was not required. Primary stenting was performed with good results. Here's the angiogram afterwards for the post-renal stent that was performed, and you'll see that it's on this next angiographic run. Good flow through there, no evidence of distal emboli seen, at least grossly. And so with this final angiogram, it looks like everything is good. The patient did come back in clinic approximately 1 month afterwards, again with the episodes of hypertension, unexplained, really bothering the daughter. And so we ordered a follow-up CTA scan. And you can see this is the follow-up CTA after we put that additional stent. The first thing you notice is you see the first stent, and you see the second stent that we placed, and you see this gap in our stent that we placed. And you can see with the thinner images obtained, these are 1 millimeter cut thicknesses, using the MIP image, cross-axial images going down the barrel. You can see the stent on the stent, and then next comes this gap area right there that's very concerning with very minimal metal, and then starts the ostium, and then there's the aorta. And so on this final angiogram, you can see the angiogram looks good 1 month later. Here's our stent. And so the question is this a stretching of the stent? And then will this lead to a stent fracture? Here are several of the images that are obtained, and you can see that concerning gap on our stent that we placed. And again, is this a stretching? Obviously, there are struts that are holding this through, because on the ultrasound there was good flow through the stent. So what's really happening here? Okay, so what is really happening here? Is the stent being obscured because you have calcium at the ostium, and then you have the stent over the stent with this double density of the two stents, and you just happen to see the gap between the two. And so is it a CTA artifact, or is the stent being stretched, leading to a potential break? And you may ask why. Well, you've got the long 22 millimeter stent connected with a 15 millimeter bridging stent to an mobile and fixed aorta. And so, well, what should we do next? Again, this is an 87-year-old male who has good ultrasound velocities but a worrisome CTA. Some of the options would be to ignore the CTA finding as an artifact, or you could bring him back for fluoroscopic evaluation to see if there's a potential stent break, or finally consider a repeat angiogram, which would be awfully dramatic. Here's a separate case which happened several years ago. We saw at university a renal stent fracture. You can see on the CT this was picked up as a follow-up, and you can see on the angiogram the stent fracture on this left renal artery. And you can see the fracture with the significant hyperplasia that developed from this, requiring intervention on this stent. And so in summary and conclusion, we've talked about the technique for renal stenting, gaining access either with a 4 or 5 French diagnostic catheter at the ostium with a coaxial approach, allowing the guiding catheter or sheath to be advanced over the diagnostic, versus that of a 6 to 7 French guiding catheter approach, either using a no-touch technique in which the guiding catheter does not touch the ostium, or a limited no-touch technique in which the 035 guide wire is left in place, advancing the guiding catheter near the ostium, and once near the ostium, the 035 is removed, allowing the guiding catheter to gently come near the ostium and allowing the 014 guide wire to cross and perform primary stenting. We also talked on the second part on stent fractures. As mentioned, this is rare, but it can occur and result in significant hyperplasia and problems, and is probably related to the fulcrum effect of the stent within the renal artery with the respirations, in combination with a weakening of the stent, allowing it to be more flexible. In summary as well, I would like to thank the organizers for the meeting for inviting me to Cannes. It's a gorgeous city and it's a wonderful part of southern France. And again, I really want to thank you for inviting me, and I look forward to coming back in the future. Thank you.